Found your solution with Health Hour. Every Saturday at 11 a.m. This is your space where Caribbean and African healthcare professionals speak about health with a focus on Black people. We tackle the topics that keep you up at night: mental health, chronic conditions, preventive care, sexual health, men's health, women's health, heart disease, and much more. All with the cultural context that matters, because our Black doctors understand the unique challenges we face. Here is what you can expect: real talk from doctors who look like you and get it, lived experience testimonies, practical advice, illness prevention and management tips, and a space of understanding without judgment. You also get to ask questions. Your questions drive the conversation. Health Hour, where community meets Black health expertise.
Good morning and a warm welcome to everyone joining us this morning at Health Hour. Health Hour today will be hosted as a joint effort between the Caribbean African Health Network and Endometriosis UK. Endometriosis UK is the leading charity on endometriosis within the United Kingdom and occupies itself mostly with education and awareness around endometriosis. Endometriosis is one of the most common gynecological conditions within the UK. So this morning we are joined by Ushma Bal, who is their engagement and volunteer manager, as well as our main speaker, who is Dr. Edmond Edi Osagie, a consultant gynecologist with a subspecialization in reproductive medicine and an interest with endometriosis and laparoscopic surgery. We look forward to hearing from you both this morning, and I will hand over to Dr. Edmond.
Thank you so much. Thank you to Khan. Thank you, Marwa, and thank you, Ushma. It's a pleasure to be here again, and I think it's really befitting that we are discussing endometriosis in this Endometriosis Awareness Month. I always say that we cannot discuss enough about endometriosis, and it is a pleasure to be here. So, as I have been introduced, my name is Dr. Edmond Edi Osagie. I am a gynecologist, and my specialist interest areas are reproductive medicine and surgery, which means I deal with the full scope of subfertility, from investigations all the way to IVF and specialized IVF treatments, and reproductive surgery, which really involves advanced laparoscopic and hysteroscopic surgery. And as we all know, over the years, that's something that has become really pertinent in dealing with the condition that we're going to address today, endometriosis. And I think it's really pertinent that we're addressing endometriosis in this Endometriosis Awareness Month. And I'm grateful that Endometriosis UK can join us to share their expertise. So let me start with dismissing a myth. Endometriosis is not a pelvic disease. A lot of people think that because endometriosis causes mostly symptoms that are localized to the pelvic area, it is a pelvic disease. It is not a pelvic disease. We now know that endometriosis is a chronic systemic inflammatory condition, and endometriosis can affect virtually any tissue in the body, any organ in the body, and a lot of people who have endometriosis have systemic impacts of that condition, and we'll come back to talk about this. So really, what is endometriosis? Endometriosis is when we find the lining of the womb that we call the endometrium in other tissues other than in the lining of the womb where it should be. So the presence of that lining of the womb outside the lining of the womb causes all the symptoms that we get with endometriosis. Because as the lining of the womb undergoes its normal changes that it does throughout the menstrual cycle, those external tissues also undergo those changes again. So they undergo buildup, they undergo inflammation, they release substances, including things that we call cytokines that can cause all sorts of inflammatory conditions. They cause inflammation of the tissues that they are attached to, and that repeated cycle of build-up and shedding and bleeding and can cause significant pain, can cause fibrosis of those tissues, can cause adhesions to form, and this is what leads to the whole spectrum of presentations that we find with endometriosis. So I'd like to talk about the concept of estrogen dependence. Endometriosis is what we call an estrogen dependent condition, and that's because women have two main hormones, estrogens and progesterones, and these hormones are vital for normal female health, normal female development, and for reproductive functioning. But the estrogen element of these hormones is what drives the lining of the womb to go through its normal development, and is also what drives the ectopic or the external lining of the womb when it goes outside the womb to undergo those changes that leads to fibrosis and all the other symptomatology associated with endometriosis. And because it's mainly estrogen dependent, if we look at this, the phase of life of women, the period where endometriosis really presents and where it causes the most profound problems are those reproductive years. So women generally only start to produce estrogens in significant amounts when they get to puberty, the average age of puberty in this environment being about 12 to 13 years. And they carry on producing significant amounts of estrogen throughout their reproductive years until they get to the menopause, the average age of the menopause being about 51 years. And this has made a lot of people believe that things like endometriosis are only found within those reproductive years, and that is what we thought for a long time. But we now know that young girls, even before the age of puberty, can actually develop and start to present with symptoms of endometriosis. And we know that endometriosis can continue to cause problems and lead to significant morbidity after the menopause. So I'll come back to talk about that briefly. So endometriosis is a really common condition. We don't have exact estimates of how many women have endometriosis for obvious reasons, but we reckon our best estimates are maybe about 1 in 10 women have endometriosis. And if you extrapolate that worldwide, we're talking of hundreds of millions of women with this condition that causes significant morbidity. And some of the peculiarities of endometriosis make it really, really challenging. One being that not everybody with endometriosis has symptoms, so you can have endometriosis developing in your pelvis and have no symptoms at all. We reckon that maybe a quarter of women with endometriosis do not have symptoms, and maybe the first time that they come to our attention is when the condition has gotten really severe and requires extreme measures to deal with it. Endometriosis is very commonly found in women who are going through fertility treatments, and in some series, half of women who are struggling to conceive have been found to have endometriosis. And that's why one advice we give to women who are trying to conceive and who've had investigations and no cause has been found for the delay in conception is that they should think about endometriosis and be investigated for that. And because endometriosis tends to be really tied in with the normal menstrual cycle, which every woman goes through, a lot of women do not get the attention they need when they first approach their healthcare providers with complaints of symptoms of endometriosis, and this can lead to a delay in the diagnosis. And in this part of the world, we reckon that it takes about 8 to 10 years for women to be diagnosed with this condition, which is just suboptimal. So what causes endometriosis? The simple answer to that is that we don't know for certain, but we have some ideas about how it comes about. So we know that there is a genetic predisposition to endometriosis. So this is not a single gene predisposition. So it's not like something like maybe sickle cell that you have the gene and you pass it on to somebody. There is a multitude of genes that we think is involved in that predisposition. And women who inherit those genes, and some women could inherit more of those genes than others, when they get to the age where they now start producing hormones, the estrogens that I talked about earlier on, then that gives the setting for endometriosis. And one other thing that has been found in these women is that the inheritance of those particular genes alters the way their immune systems work. So their immune systems do not work in the same way as women who do not have those genes. And so, for instance, they struggle to be able to clear away those cells that emanate from the lining of the womb that should not be found in other parts of the body. So when women who do not have these genes are able, their immune systems are able to gobble up these cells and get rid of them, the women with the endometriosis genes are just not able to do that. And that creates the setting for endometriosis to develop. So there are different types of endometriosis, but this graph just summarizes how we think the most common type of endometriosis, which is a peritoneal endometriosis, comes about. So I'm sure everybody's heard about retrograde menstruation. What that means is that as women have periods, most of the blood passes through the cervix and into the vagina and outside the body. But in every single woman, there's a small amount of blood that passes through the tubes during periods and goes into the pelvic cavity. For the vast majority of women with normal immune systems, their immune cells just gobble up all that blood and all the cells within the blood and get rid of them, and they don't lead to any problem. But in the 10% of women who go on to develop endometriosis, because of that alteration of their immune systems, these cells are not gobbled up properly, so they start to attach to tissues in the body, the womb, the tubes, the pelvic peritoneum, other organs of the pelvis. And when they attach there, as the lining of the womb develops monthly with estrogen proliferation, those other tissues start to develop as well. And then they shed and they cause all the symptoms of endometriosis. So we do find that women who tend to have heavier periods pass more of that blood through the lining, through the tube into the pelvis, and they are at increased risk of endometriosis. Women whose periods are more frequent are also at increased risk of endometriosis because of that finding. And also women who start having periods very early on, say maybe before the age of 11, 10 years, they are also at increased risk of endometriosis for this basic reason. So we think that this way is how the most common type of endometriosis develops. But endometriosis is an enigma because we know it's not one homogeneous condition. Endometriosis has been found in virtually every tissue in the body, and it can affect women in different ways. So we can find some women who have one spot of endometriosis who are moribund from pain, and we can find other women who have florid endometriosis all over the pelvis and have no pain at all. And women can have exactly the same nature, exactly the same lesions of endometriosis and present in totally different ways. So it is a very enigmatic condition. And we now know that there are different types of endometriosis, and I'll just describe those types. So the most common type is the peritoneal endometriosis. So the peritoneum is the lining of the pelvis. So that's the tissue that lines the whole of the pelvic organs and the pelvis and the abdomen. And when endometriosis develop on those walls, that's the most common type we find. But there are other types. So the endometriosis that involves the ovaries, that can form cysts in the ovaries. That's what we call endometriomas. And then there are the deeply infiltrating nodular endometriosis. So these are the type of lesions we find going into bowel, going into bladder, going into ureters, and other organs. And they go deeply, and those can be challenging to treat. And then for a long time, there's been this debate about whether the uterine endometriosis, called adenomyosis, is a type of endometriosis, and some people have felt that it isn't a type of endometriosis. Other gynecologists have felt it is. I'm pleased to say that the consensus appears to be coalescing around the idea that uterine endometriosis is actually a form of endometriosis, and that's the school of thought I belong to. And then there are extragenital lesions, which are lesions that are outside the pelvis, and I'll show examples of those as well. So this is pictures of peritoneal endometriosis, and you can see these are endometriotic lesions. So all of these, so that's the womb there, the ovaries and the tubes on both sides. All these black lesions you can see here are lesions of endometriosis. So that is what happens, and these are well mature, established lesions of endometriosis. So when these endometriotic cells are deposited in the pelvis, over time they undergo changes, and over time there's a lot of bleeding into the tissues, and blood of what we call hemosiderin, that's a part of the blood, gets deposited in these tissues, and that's what eventually gives rise to this black color. So all of these lesions will probably be affecting nerves. They can be going deep and affecting tissues deeper underneath the peritoneum. And sometimes this type of endometriosis can affect a lot of other pelvic organs. You can see how stuck together all of these pelvic organs are, the tube, the ovary, everything stuck together, stuck to the womb, and this will be a significant source of pain. So this is the most common type of endometriosis, and it causes mostly pain. It can impact fertility, especially if it affects the tube, as we can see here. But the good thing is that this is very, very amenable to surgery. So this is another fairly common type of endometriosis. So this is endometriosis affecting the ovary. You can see there's a big ovary there that's been enlarged by a big endometriotic cyst. And these, if they grow very quickly or if they rupture, as you can see in this bottom picture here, they can give rise to significant pain that might lead to an urgent operation. The sad thing about this type of endometriosis is that it can impact ovarian reserve very significantly, so it can cause damage to the eggs in the ovaries, and that can lead to impairments of fertility and also lead to an earlier menopause. But again, these are very, very amenable to surgery, so very treatable. So the third type of endometriosis is what we call the deeply infiltrating endometriosis, and these are the ones that go deep into the tissues. So by definition, when these go more than 5 millimeters into the tissues, they get into the category of being deeply infiltrating. So this picture here on the left top picture is endometriosis involving what we call the rectovaginal septum. So this is the area of the vagina, at the top end of the vagina, at the back of the womb, and that can be a source of significant pain and be a source of significant sexual dysfunction because it causes very severe pain, because during intercourse this is where the penis actually impacts, so that can be a big source of pain. And this is a bowel we can see down here, and these lesions can easily grow and invade into the bowel, as you can see in the picture below there, and this can cause significant morbidity and be challenging to treat surgically. And on the right side, the picture you can see here is endometriosis involving the bladder. So when we do a laparoscopy, looking at these lesions from the pelvis, this is the kind of picture we see. And if we put a camera into the bladder, that's the kind of picture we see. These are the endometriotic nodules. So these are all deeply infiltrating endometriosis, but they are amenable to surgery. And this is a uterine endometriosis or adenomyosis, as you can see. And there are two types. You can have the diffuse adenomyosis, as you can see in this picture, or you can have the what we call the focal adenomyosis, where it just forms lesions that are circumscribed. And this can easily be confused for fibroids because it can cause very, very enlarged uteruses, as you can see in this bottom picture here. It can impact fertility significantly, and it can be a significant cause of menstrual dysfunction and pain. But there again, these are all amenable to both medical and surgical treatments. So these are some examples of extra genital endometriosis. You know, as I mentioned at the beginning of my talk, endometriosis has been found in virtually every tissue in the body, and there are examples of this and some of the things that they cause. And some pictures of the ones we have seen locally. So there's endometriosis of the belly button here on the left, and this lady presented with bleeding and swelling and pain of the belly button during each period. This is endometriosis involving an episiotomy scar, and similarly she presented with swelling, pain in the episiotomy scar during periods, and this was a significant impediment to sexual intercourse. The right picture there is endometriosis of a cesarean section scar, and similarly this presented with swelling and pain during periods. Now the bottom picture there is showing endometriosis of the diaphragm. So this is the liver here, and these are adhesions due to inflammation, and those black spots you can see beyond the adhesions, these are all endometriotic lesions on the diaphragm. So all these are the kind of things that we can see when we do laparoscopies. And this picture here shows endometriosis involving the lungs here. So this right lung here has just been completely taken over by endometriosis. But again, just to show you that all of these are amenable to treatment, this is after 18 months of medical treatment. The lesions are completely resolved. So let's talk about the morbidity of endometriosis. The main issue we have with endometriosis is pain. Endometriosis is a significant cause of pain, and sometimes that pain can impact functioning, and I'm pleased to note that I think there's some discussion about women being able to take paid leave for up to 3 days during their periods. I think Ushma would maybe enlighten us a bit more about what's going on with that drive. But I think that's a very, very welcome development. Endometriosis can cause sexual dysfunction, and in some people it can completely interfere with sex and stop them being able to have sex. It can cause menstrual dysfunction, from heavy, painful to regular periods. Some of the other things that we don't talk about very, very commonly about endometriosis is fatigue. Endometriosis is a significant cause of fatigue. And the way to think about this is endometriosis is a chronic inflammatory condition. And if you think about how you feel when you are unwell, maybe you've got a flu or cold. There are some women who have flu-like symptoms during each period when they have endometriosis, and they're just unable to function normally. Because of all of these, it's a significant cause of poor quality of life. It can impact on women psychologically, so there is a lot of psychological dysfunction in women who have endometriosis, especially the severe types of endometriosis. And we've mentioned before how it impacts fertility. And these are some of the ways endometriosis can affect fertility. It can interfere with sexual exposure. And when people are able to have intercourse, because of the damage it can cause to fallopian tubes, it can impede the sperm and egg coming together, so fertilization doesn't take place. And when fertilization happens, it can impair implantation of that fertilized egg because of the alteration it does to the developing lining of the womb. As well as it can impair the sperm being able to penetrate the egg, reducing fertilization. And even when people can conceive, we know that women with endometriosis have a higher risk of miscarriage because of the biological impact on the development of the lining of the womb. And we already talked about how it can impact ovarian reserve by diminishing egg count and quality in the ovaries. So endometriosis does have significant impacts on fertility. And from studies that have been done, these are some of the other comorbidities that we have found with endometriosis. A lot of young ladies, I'm sure, would relate to this, where you keep going back to your doctor and you're told that you have irritable bowel syndrome, and we know that 50% of women with endometriosis have bowel dysfunction, but sadly this can lead to a delay in the diagnosis of the condition because they get treated for bowel dysfunction rather than diagnosing the condition. Migraine headaches, fatigue, cystitis, fibromyalgia, eating disorders, and as I mentioned earlier, up to more than 50% of women with endometriosis show some psychological dysfunction. So these are all the things that lead to the diagnostic delay with endometriosis, but we are beginning to try and improve that situation, removing some of these myths about endometriosis, empowering women to be able to demand a second opinion if they feel that they have not been listened to. And we no longer rely on laparoscopy as a way to diagnose endometriosis, but rather most of our diagnoses, I'll say in over 90% of cases, we make a diagnosis of endometriosis before we actually go to theatre to use a laparoscope. So I'll just highlight these red flags, and these are things that should warn people that there is a high chance that they might have endometriosis. So when people have severe pelvic pains, whether they are cyclical pains or constant pains that are interfering with their everyday functioning, they should think about endometriosis. Anybody who has menstrual pains that are preventing you from going about your normal duties, from going to work, from engaging in social activities that isn't normal, you should think about endometriosis. And pain should not be, sex should not be painful to the point where you're unable to engage in intercourse. So again, if that's happening, you should think about endometriosis. Endometriosis, as I mentioned previously, can cause significant bowel dysfunction, and one of the ways this can present in women is abdominal bloating. So women who suffer with abdominal bloating, especially in the second half of the cycle leading up to their periods, and women who have a lot of bowel dysfunction in those periods and in those stages of their cycle and in their periods as well. So bowel habits that fluctuate between loose stools and constipation, painful bowel habits, urgency of bowel motions. Again, those are red flags for endometriosis. Similarly, urinary dysfunction. There are many ladies who come to us and they've been going to see other doctors for ages, and they've been told they have repeated UTIs. Each time they get treated, it doesn't get rid of the symptoms, and then they eventually notice that those repeated UTIs tend to be coinciding with certain times in their cycles, and then they come to us. So if you keep getting urinary dysfunction and keep being told you have UTIs, you need to think about endometriosis. I mentioned previously that endometriosis can cause flu-like symptoms during periods in some women. Anybody who experiences nausea, vomiting, flu-like symptoms during periods, those are red flags for endometriosis. And similarly, as I mentioned previously, if you're struggling to conceive and you've had all the investigations and nothing has been found by the doctors for the delay in conception, you've got to think about endometriosis. And these days, it's quite straightforward for us to have an impression of endometriosis from the history we take, from doing vaginal and rectal examinations, what we find from those, and from undertaking imaging studies, mostly pelvic ultrasound scans. We're able to have a fairly good indication whether a woman has endometriosis and the stage of the condition in up to 90% of patients who come to us. And in a very, very few cases where we have to extend that to undertaking more invasive radiological investigations like MRI scans. So that when we really reserve doing a laparoscopy now for treatment of endometriosis. There are very, very few instances where we will need to do a laparoscopy as a diagnostic procedure for endometriosis, and those will really relate to very severe cases where we need to do what we call a staging procedure in conjunction with other specialists like urologists and colorectal surgeons that we work closely with. So on the left is what a healthy pelvis looks like, and on the right is the kind of pelvis that has been afflicted by endometriosis. So how do we diagnose this condition? There are people who talk about biomarkers for endometriosis, and I know this is getting some traction. The one thing I'll say is they have not generally been studied enough to be of proven value, and we currently do not use them for routine clinical work. Okay, so that's all I'll say about biomarkers for now. So in managing endometriosis, we take what we call a holistic approach. So we do not treat endometriosis as a condition by itself. We treat the person who's coming to us, and we take the whole presentation of that person. So maybe a 20-year-old girl who's coming to us with pain, we might manage her in a slightly different way to a 35-year-old lady who's coming to us with pain, with infertility, and so that all those things determine, and we'll treat somebody who's coming to us at the age of 45 as well with similar symptoms. So we treat the person coming to us, and we adopt a holistic approach. By far, the mainstay of management of endometriosis is surgical, but there are a vast array of medical options that we have for managing endometriosis. And because pain is a significant part of endometriosis, we do work very closely with pain specialists. So sometimes we work with complementary therapists who provide acupuncture and other pain therapies, as well as our chronic pain management specialists. Counseling is a significant part of managing endometriosis. Nutritional support is very, very important, especially for patients who have significant bowel dysfunction with IBS type symptoms. So our approach to endometriosis is very holistic. Now, this is a provocative slide, and I've been challenged before on this slide, but I keep putting it out there because I think we need to start changing the narrative of endometriosis. In the past, we used to tell people endometriosis is not a curable condition. And I've had a lot of women who come to me and say, oh, well, if this condition is not curable, why should we even bother? Why should we bother get treatment? Why should we bother go see somebody? And I think we need to be changing the narrative, because although by the very nature of endometriosis, it can come back, But what we find and what the studies tell us is that in 2/3 of women we treat properly for endometriosis, they do not come back. They go on and they live their lives happily ever after. So with good treatment of endometriosis, a lot of that condition can be managed to the point where women are able to just get on with their lives and they don't have a need to come back for further treatment. And if that's not a cure, I don't know what is. So I have changed it, and I have started telling people, yes, we can cure endometriosis, but in up to 1/3 of women, it can recur. So that if you get symptoms again, then come back to see us. It's really important that we start to put this narrative out, because it's important for ladies to know that the earlier they come to us with their symptoms, the greater the chance that we can get rid of this condition and give them the opportunity to live their lives free without endometriosis for a long time. There is a really good publication by the European Society of Human Reproduction that gives a lot of information about endometriosis, and I'll encourage anybody who wants to know more about this condition to try and get this publication. If you go on the ESHU website and you search for endometriosis patient guidelines, you'll bring up this publication to you. Okay, so I'll just highlight a few important things in my home straight going about some dietary strategies. We talked about estrogens being the main hormone driving endometriosis, and we know that there are some dietary substances we take that can increase estrogen levels, and so they are called pro-inflammatory dietary substances. So things like sugars, sweet things, starches, white flour, pasta, red meat, red wine, those kind of things. And what we have found is that women who can change their diet to avoid those things, and even some women find removing gluten from their diet really, really helpful, that can help to reduce the inflammation and increase their fruit and veg, fish, and those sorts of things. So this can be really helpful, especially for women who have bowel dysfunction. So medical management of endometriosis, there are loads of medical ways we can manage endometriosis, and the main way to do it is by reducing pain. There are two things endometriosis commonly causes: pain and subfertility. And medical management, if we can address the pain, we can improve the quality of life of a lot of people suffering from this condition. So painkillers, especially the non-steroidals like ibuprofen, can be really helpful in managing endometriosis. Again, because estrogen is the main driver of this condition, anything that antagonizes estrogen action, like progesterones, you get in the pill, the progesterone-only pill or the combined pill, or anything that reduces the production of estrogens, like suppressing the ovaries, can be really helpful for managing endometriosis. So there is a whole spectrum of medical management options for endometriosis. There's a very exciting study going on in Scotland that some people may know about, where a drug called dichloroacetate is being trialed. It's not a hormone. That's the most exciting part of it, because sometimes women get side effects from hormones. So this is the first non-hormonal preparation, and that has been investigated for management of endometriosis in a long time. And we're very excited because the phase 2 trials are showing very, very encouraging results, where we're getting significant improvement in women's symptoms in up to 80% of women. So we're very, very excited about that. So we're awaiting the conclusion of those trials. I think they'll be out in maybe another couple of years. So the mainstay of endometriosis treatment is surgical, and virtually all the types of endometriosis I described to you are amenable to surgery, and we do apply laparoscopic surgery because that gives us the best way of reaching the deepest parts of the pelvis with lower complication rates, lower infection rates, better cosmetic outcomes, and preservation of fertility. And because I always get asked about what happens during laparoscopic surgery, I'll show you a very short video that gives you an indication of what we do when we do laparoscopic surgery. So it's really important when we do laparoscopic surgery to do what we call peritoneal mapping. So this is where we look at the whole of the abdomen. We start from the upper abdomen and work our way down towards the pelvis. So that helps us to identify where all the endometriotic lesions are. For women who are trying to conceive, it can help us to assess the tubes. And then we'll go ahead and do the removal of the lesions. So as you can see, what we do with removal of the lesions is what we call pelvic peritoneal excision. And to give us good access to the pelvis, we hold the ovaries out of our way, like we're doing now. Okay, these are temporary, and we release them at the end of the operation. So you can see we've got really good access. We know where all the lesions are, and we use really sophisticated instruments that help us seal the blood vessels in the pelvis. And you can see with the laparoscopy, our vision is magnified, so we see all the blood vessels clearly. We know where they are, so we can seal them and stop bleeding, prevent bleeding. We see where all the nerves are, we see where all the vital organs are, and that helps us to protect them in removing endometriosis from the pelvis. So in the past, we used to do things like ablation surgery, where we'll go in and just burn off the lesions, but it became clear over time that that was not an optimum way of dealing with endometriosis, and that resulted in a significant amount of recurrence of the condition. Most endometriosis specialists now will do excision surgery, which is what I'm showing you now. And again, when we started doing excision surgery in the early days, we just used to go to where the lesions were and excise the endometriosis around the lesions. And over time, what we realized was that endometriosis can be at different stages, and there will be both macroscopic lesions that we can see and microscopic lesions that will not be visible to us. And by just going to the endometriotic lesions and removing them, we were leaving those microscopic lesions behind, and that led to the development of this concept of pelvic peritoneal excision, where we remove the whole pelvic peritoneum, and that gets rid of both the microscopic lesions and the macroscopic lesions. And as you can see, this procedure has been going on now for some time. There's no bleeding at all because the vessels are sealed properly. We know where the vital organs are. We can protect them, and it's a really fantastic way of treating endometriosis. And the good thing about this as well is this peritoneum we're removing from those patients will be completely reformed, and a new peritoneum formed within 4 weeks of the surgery. So endometriosis is very treatable, and that's just an example of what we do with surgical management. So essentially, we're converting a pelvis from what you can see on the left to what you can see on the right. And as I said, within 4 weeks, that peritoneum is completely reformed. So we now work in multidisciplinary teams. That's how we provide excellent endometriosis care. There are about 80 what we call BSGE endometriosis centers in the UK, and those are centers that are accredited by the British Society of Gynaecologist to provide endometriosis care. And my recommendation is that anybody who's suffering with this condition should try and get seen in an endometriosis center, because that's where the multidisciplinary team specialists are available, and each endometriosis center has to audit their records and be comparable to their peers across the country. So if you like, that's where those are the pinnacles of endometriosis care in the UK. Okay, before I finish, just to encourage everybody listening, I always feel you have to take control of this condition. You got to help yourself, and I thank Can for putting on this talk. By talking more about it and by making women more aware of what the condition is and how to manage it, we're giving them a better understanding of how their bodies work. And there are many publications out there as well that help women to understand what endometriosis is and how they can help themselves. There are several self-help measures. The one thing I encourage women to do is to keep a menstrual calendar. It could be something as simple as this, where you just write down the days and the months and you record your symptoms, whether you have pain, whether you have menstrual bleeding, and the level of it, because that's really helpful when you go to your doctor for a review, and it can speed up your management plan. Be assertive. I really think this is important. I think a lot of people get fobbed off that, endometriosis is just, or painful periods are just a woman thing, and deal with it. But I think there is now the option to request a second opinion, and I think this new law that has come in now, where if you go to your GP 3 times with the same symptom, then they have to arrange for you to be seen by somebody else. So be assertive. I always say women know their bodies more than the doctors they're going to see. And if something's not working well with your body and somebody is telling you that's not the case, request to see somebody else. So educate yourself, keep a diary of your symptoms, think about dietary manipulation, and seek out an endometriosis specialist. So endometriosis is very, very treatable. Okay, so the earlier you present, the more the chances of getting rid of the condition for you and giving you a new lease of life. And I'll just finish by saying endometriosis can impact the ovaries. So women who think they have endometriosis, I'll always recommend that they have a check of the ovarian reserve. Just a simple blood test, your AMH blood test can give you that. I encourage people to think about doing that. So thank you very much. I'll stop there for now.
Thank you very much for that talk. Lots of questions from the audience, and we promise we will get back to you. But first, without any further delay, we've got a talk coming up from Ushma Ball from Endometriosis UK, the leading charity on endometriosis within the United Kingdom, for those who've joined later. So Ushma, over to you.
Lovely. Thank you so much. That was so informative, even for me, Dr. Edmond. So thank you so much. It's always stuff we can learn. Thank you for the introduction. Yes, my name is Ushma. I work for Endometriosis UK, which is the largest charity supporting people with suspected and diagnosed endometriosis across the country. I'm going to quickly whiz through a couple of slides because I'm conscious people have questions and it's probably more important to answer those questions. But just to say, sadly, this is the state of endometriosis care in the UK currently. So Endometriosis UK launched a report early part of this month, March being Endometriosis Action Month. And what we do know is that sadly, the state of care for endometriosis across the UK hasn't improved since our last report that we published in 2023. So as a charity, what we're trying to do is help drive that change, which is really important for people. We know that currently, on average, the sort of diagnosis time for endometriosis is 9 years and 4 months across the UK. And obviously, if you live in different nations across the country, that time looks very different. So you'll see kind of people in Scotland have a longer waiting time. What we do also know is on the back of this data that we've launched through the survey that we ran at the end of last year and early part of this year, is that for ethnically diverse communities, diagnosis takes longer. So we're looking at 11 years on average, which is really, really shocking, given the symptoms Dr. Edmond highlighted. And, you know, for many individuals, these symptoms will impact on everyday life. The symptoms will vary from person to person. And in some cases, you know, for some people, the symptoms might be cyclical, intermittent, and persistent, which means it impacts on everything. It can impact on relationships, well-being, employment status, and so on as well. So as an organisation, there's lots that we need to do in terms of supporting people and advocating for those with endometriosis. So just to give you a very quick idea, we've currently got this is some data that was released by the RCOG, which is the Royal College of Obstetrics and Gynaecology, and basically the number of people waiting on a hospital gynecological waiting list would fill Wembley Stadium 8.5 times over. So again, those figures are pretty shocking for us as a charity, which is why we're committed to really sort of driving change. So in terms of what we're doing is we're calling on the government of the UK to commit to reducing the diagnosis time to a year or less by 2030. Given that we're looking at a diagnosis time of average of sort of 9 years plus at the moment, that's a really ambitious ask. However, we think that that's what people with endometriosis deserve. We're also urging NHS commissioners to provide, kind of to drive down these gynecological waiting times, and also kind of making sure that all healthcare practitioners receive training on menstrual health and endometriosis as well, so that people don't have those repeated kind of, visits to the GP and doctors, and sort of not getting the answers that they need. As a charity, what we also do is work with the various different research teams. So, it's important for us to really kind of advocate for more money and more investment into research as well. So in terms of advocating for yourself, we do a lot of work across our support services with people on their journey, and it's very much around kind of encouraging people to really think about preparing ahead of those GP appointments, preparing ahead of any kind of appointment they might have, encouraging people to be really open and honest, and as Dr. Edmond said, kind of your body best, really. So again, keeping a symptom diary, a pain diary, kind of keeping tracks of various different things, triggers and so on, and kind of going into those appointments feeling that you're able to kind of ask as many questions as you want to, as well. I mean, sometimes what people find is really, really helpful is to take somebody with them. So again, another set of ears in that room is really, really helpful for people. So again, we explore those different options with individuals as well. So in terms of how we support people to make the most out of their GP appointment, there'll be things like we encourage people to take notes with the consent of the people in the room. Sometimes it's helpful to record that conversation as well. Preparing your questions ahead of the appointment as well, being proactive in the discussion as well, kind of working through the list of questions that you might have and sort of ticking off the questions once they've been answered and so on. We do have a nurse support helpline that we run as a charity as well, which is a really, really useful resource. So again, it's an opportunity for people to speak to a gynecological specialist nurse. And again, on the back of those appointments, if there's been sort of information that's been covered and discussed and you want to kind of think about what that means in terms of kind of your own care, then that's another safe space to be able to kind of, unpick some of those conversations as well. And it's a free service as well, so people can book as many calls they want with the specialist nurse. So as a charity, what we do a huge amount in terms of campaigning for change and improvement. So for example, this week we have been in the Scottish Parliament, we've been in the Welsh Parliament, and we've been at Westminster, really kind of highlighting people's experiences around endometriosis, but also kind of looking at what the government can do in terms of helping people with endometriosis. We provide a lot of information to help raise awareness, as we know that information is power, knowledge is power. So kind of this information, which is medically approved, the idea is that it helps people to navigate the care system and also kind of advocate for themselves as well. A huge part of what we do is connecting those across the endometriosis community. We know that it's a condition that affects 1 in 10 people, those assigned female at birth and women, and it can be extremely isolating and extremely debilitating. So through our support services, through our webinars and so on, it's a way for people to connect with others across the endometriosis community. And finally, we do a huge amount in terms of influencing policy and key decision makers. So again, working with the government around driving down diagnosis times and improving access to care and treatment as well. So just a little bit in terms of what resources and support is available through Endometriosis UK that anybody can access across the country, because I think it's really, really important to know what is out there. We have support groups that we run. The groups are run by volunteers who have lived experience of endometriosis, so they understand. And these support groups run across the country. They are all listed on our website. So again, you would just need to visit the website, and it lists all the different groups that we've got happening around the country. We have a free helpline and a web chat service that's available as well, which is again run by volunteers with lived experiences. And there's an online community, an online forum community, which is there as well. So again, that's another way in which people can access support. We run lots of different information events. We ran one in Manchester, which I know is where Dr Edmond resides, but we ran one in Manchester at the early part of the year. And those living with endometriosis information days are an opportunity for people to come together, access information, understand developments in endometriosis care and so on. We run monthly webinars. Webinars are free for people to access. We have one that's running this month around kind of navigating care and sort of making the most out of appointments. We're looking at running another one around bloating. So again, those webinars are run by medics within the field of endometriosis, and are another way for people to keep informed. As I mentioned, the nurse support helpline, which is something that we launched at the start of last year, which is an incredibly valuable resource now. And we're looking to develop that in time to come as well. So it gives people a space where they can speak to a medically trained nurse to answer those questions and ask those questions as well. We have the symptom checker again, which is on the website. So again, for those at the early part of their journey, it's an opportunity for them to kind of check where their symptoms might align. And if those symptoms align with endometriosis, the symptom checker produces a letter which the individual can take to their GP to sort of say, my symptoms point to endometriosis. Can we investigate endometriosis, which I think is a nice tool for people to have. And finally, we have the endometriosis friendly employer scheme, which is a scheme that we run to support people and employers across the country. And really kind of it's around working with employers to help people thrive in the workplace. What we do know is 1 in 6 people have to give up their work due to endometriosis. So really, when we work with employers to look at some of the adaptations, thinking about sort of some of the flexibilities that they might need to consider, we can support people to remain in the workplace. So this kind of gives you a quick idea of the different endometriosis friendly employers that we have working with us currently. This is a snapshot. This is not all of them. We have over 100, but kind of what we do find is that when these employers do work with us to make those changes around kind of policy and training and resources and communication and breaking down some of that taboo around menstrual health within the workplace, people do thrive in the workplace. They're able to remain at work. But also kind of some of the flexibilities and considerations that are put into place also benefit other people with other menstrual health conditions as well, which is a real positive. So finally, just a few sort of things to consider here, kind of the idea around kind of knowledge is power, which is where the website comes in and what we do comes in. It's really important to keep yourself, kind of informed and sort of knowledgeable. And so the website does have a whole host of kind of resources on it as well. So we would really encourage people to even just go and have a look. Thank you.
Thank you both very much. So although you have talked about a wide breadth of the symptoms and everything else around endometriosis, people still have a lot of questions, and we'll try to address them as much as we can within the next few minutes. So the first question that popped up for me was, what causes a woman to have clotting during periods and regular periods for every 16 days, so short cycle?
So there are many reasons why a woman will have clotting. The presence of clotting during periods essentially means that your periods are heavier than they should be. And there are many things that can cause that, all the way from endometriosis to fibroids, and some other medical conditions can also cause that. If you're having periods every 16 days, that means you have some sort of hormonal dysfunction, because normally if you're ovulating regularly, then your periods should be not as frequent as that. So it will indicate that there's some degree of anovulation or irregular ovulation going on, and again, that can be addressed. So my strong recommendation is that you have a chat with your GP and get referred to a gynecologist, where they can just do some simple investigations for you to find out. It could be that this is all down to one condition or a combination of, one or two different conditions, but they are imminently all manageable.
Thank you. I hope that answers their question. Following up on that, Dr. Edmond, can I just ask, and maybe Ushma wants to pitch in as well, what does a normal period or a healthy period look like? Because a lot of women obviously experience pathological periods without realizing it.
Absolutely. That's a really great question. So if we start from the very beginning, the one thing to say is that women will vary in terms of how they assess their periods. So what might be heavy to one person might not be heavy to another person. So in determining whether a period is heavy or not, we have to take the woman into consideration. And the one thing we did, the one guide we generally go by is that if somebody approaches us to say, I think my periods are heavy, we take that as a given, and we look into why their periods should be heavy for them. Okay. Now, when we talk about the cyclicity of periods, we generally say a regular menstrual cycle is a good indication that somebody is ovulating regularly, and because they're ovulating regularly, there's somebody speaking in the background. I don't know if
yes, Samuel.
Okay, I'll carry on. So when we talk about the regularity of menstrual periods, we normally class normal cycles as cycles that range between 21 days and 35 days, but do not vary from cycle to cycle by more than 7 days. So typically there'll be a range of cycles. So if your cycles are lasting between 22 and 26 days, then we will class that as normal menstrual cycles. If they are lasting between 30 and 34 days, we will class those as normal regular menstrual cycles. But if they are varying from 20 to maybe about 37 days, then we will clearly class those as irregular cycles, because the variation is greater than 7 days. And when it comes to the periods themselves, we normally would class normal periods as those lasting between 2 days and 7 days. So if your periods are lasting less than 2 days or longer than 8 days, we will class those as too light or too heavy. And they might be indicative of different undergoing conditions. So the important thing is any menstrual cycle that is irregular might be indicative of some underlying hormonal condition. Any menstrual cycle that is too heavy, too painful, might be indicative of some abnormal pelvic pathology like fibroids or endometriosis or pelvic inflammation. And in those conditions, I recommend that you just have a chat with your GP or see a gynecologist and get some simple tests done to determine what's going on.
Thank you very much. Ammonia has asked, with endometriosis, is it possible to have pain on one period and no pain the next?
That's a really good question, and that's something that we have heard from some women. We don't know why that happens, but the simple answer is yes, it can happen. There are some women who tell me that it's when they ovulate from one side that they get the pain, and that is possible. If endometriosis, as I showed you in my graph, in my slides, can cause adhesions and can cause your ovary to be stuck down to one side, and presumably somebody who's ovulating from that side will probably feel more pain because that ovary is not mobile and not able to expand without causing pain. So I think the simple answer is we have seen that in some women with endometriosis, and so it is possible, yes.
Thank you. So I will do one last question, which I'm going to try to combine two. So one person in the audience asked about what treatments are available for a 15-year-old. And obviously, before we talk about treatment, we should talk about investigation. So there is a colleague in the audience called Maria who's asking what can doctors do to reduce the diagnostic delay. So I assume non-gynecologists who are seeing women with abdominal pain. At what point do we refer for further investigations, as many symptoms are non-specific? Would we refer straight to TVUS for people in the audience? That's a transvaginal ultrasound. Or should we seek a gynae opinion first? So if I may combine those, who qualifies for a referral to a gynecologist when seeing their GP?
That's a really, really good question, and I think there isn't a right or wrong answer to this, and there isn't a right or wrong approach, and ultimately it will depend on the person you're seeing and what they present to you with, and generally, the younger the patient, the more likely it is that you can afford to. It's very, very valid to see a 15-year-old who you suspect might be struggling with symptoms of endometriosis, and decide to treat her hormonally first by putting her on the progesterone only or the combined pill to see if that manages her symptoms and helps her to reduce the impact of whatever is going on her schooling, on her life generally. Those are very, 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 very viable options. What I will say is, if after applying treatments like that, the person is still struggling, or those treatments are not helping them, or they are intolerant of those treatments, then I would say that is the stage that I will be referring somebody. I know it's difficult as a GP to be familiar with all of the signs that we pick up when we examine women with endometriosis, but I think we should have a low threshold to arranging a pelvic ultrasound scan for women who come to us with pelvic pain, especially if maybe we've tried to treat them with a hormonal preparation for about 6 to 12 months and we haven't had an improvement in their symptomatology. I think pelvic ultrasound scans are a good screening tool for determining which women should go on to see a gynecologist straight away. But ultimately, I would say anybody you're struggling to manage their symptoms, who keeps coming back to you, please send them to a gynecologist.
Thank you. So one question to Ushma. S. Addo asks, how does one request reasonable adjustments at work? I'm scared of losing my job. Any ideas, please? So that really touches upon the endometriosis friendly employer. Any advice?
I mean, it's those kind of conversations can be really, really difficult because you don't know how it's going to be received. And actually, it can create a lot of anxiety, a lot of worry, a lot of stress for people because they don't want to lose their job. I mean, it really, really depends. I think kind of in the first instance, I would, we would encourage people to get in touch with us to speak to our endometriosis friendly employer scheme program manager. And again, we can sort of explore options and ways in which kind of they can approach those conversations. The support services that we run as well are a really good kind of information source as well, because people will share their experiences of what's worked for them or what hasn't worked for them, and that kind of gives people kind of ideas as well. So I think, kind of maybe sort of a combination of those two different sort of approaches is a good starting point, as well as sort of looking at the website. I think it's important to think about, when you're thinking about conversations with employers as well, what's going to sort of, we can't expect employers just to do absolutely everything. So there's got to be some flex within that. And I think it's also sort of thinking about what can help you. So being very specific in terms of what might help you at that point in time, but also kind of where the flex might be for the employer as well. But I would definitely encourage, individuals to look at the website for a bit more information around tips and how to navigate those conversations.
That's lovely. Thank you very much. With this, I will have to conclude the talk. I appreciate lots of people still have questions. We've unfortunately overrun because of the great engagement. For those of you who still have the feeling that their questions weren't answered, please do get in touch with us via email, which is healthhour@chn.org.uk. Alternatively, please do visit the Endometriosis UK website, which is endometriosis.uk/org. And hopefully between those two, you will find the answers you seek. Thank you very much, Dr. Edmond and Ushma, for your fantastic and engaging talks. I have personally learned a lot, and I can imagine the audience even more. And I will now hand over to Ella, who will do our final conclusions, and wish you all a lovely rest of your day.